Gabe?
Yes, yes.
Okay. Well, it looks like we got about 35 or so people on the line, 37 maybe. So good afternoon, everyone. Thank you for joining us. I think we will be discussing using serum tears to treat dry eye syndrome today. My name is Melissa Bailing, and I'm the compliance director at ArcPoint Franchise Group. I am also the product owner of Serum Tears, which is a very dear to my heart service line that we offer through our ArcPoint Labs locations. We have the privilege of partnering with Kits, who supplies our local business owners with the kits to produce the same day serum tears. You may have already heard us chatting a little bit about that. In a few moments, I'm going to be turning things over to Gail Thorne, the CEO of Kits, and he'll formally introduce Dr. Ward. But I just want to mention a few housekeeping items before we get started. We are recording, so if you're on here, you're being recorded. Feel free to utilize the chat feature here on Zoom, and we will be sure to get through as many questions as we can by the end of the call. And if for some reason we run out of time, no worries. You have local representation, you've got the corporate office, lots of people who can get in touch with you to make sure you have all of your questions answered. We also hope that you can stay through for the whole call, but we understand that everybody's busy and you may have to step away. So if you do, anyone who has registered for this call, you'll get a link with the slide deck and the recording of this webinar. We're also going to host additional sessions in September and November, so stay tuned for those invites. So yeah, without further delay, Gail, I'll turn things over to you to formally introduce Dr. Ward.
Wonderful. Thank you so much, Melissa. And I could go on and on and on about Dr. Ward, so I will try and be brief and to the point. So Dr. Ward specializes in the diagnosis and treatment of corneal and external eye diseases, cataracts, ocular surface diseases, and surgical correction of nearsightedness, farsightedness, astigmatism, and presbyopia. I should mention that Dr. Ward gets the doctors in his area refer to him as the guy that handles all the train wrecks. In other words, the most difficult cases in the area are referred to Dr. Ward for those patients to get help. He graduated from the University of Utah Medical School with his medical doctor degree. Medical school. He worked at Newton Wellesley Hospital, Newton, Massachusetts. I worked at the University of Iowa City for his residency. And he's a board certified ophthalmologist by the American Board of Ophthalmology and a member of the American Academy of Ophthalmology, the Cornea Society, the American Society of Cataract and Refractive Surgery, and International Society of Refractive Surgery, the Utah Ophthalmology Society, and the Iowa Eye Association. He has a special appointment as an examiner for the American Board of Ophthalmology. He's a native of Salt Lake City. And Dr. Ward also does a lot of, he's not only a very knowledgeable physician, but he also provides a lot of free medical care in countries including Peru, Nepal, Eswatini, Romania, and the Republic of Moldova. And so with that, I'll turn the time over to Dr. Ward. And thank you, Dr. Ward, for your presentation.
Thank you, Gail. And Melissa, thank you as well. It's good to be here joining all of you. This looks like a pretty good group, one of our better turnouts, I think. And makes me wonder if some of you may be getting this the second time through. So hopefully it's not as boring as it was the first time. I'm going to bring this presentation up. Let's see if this works to share my screen. Do you see that?
We do.
Is that full screen for
Full
people?
screen.
Okay, good. Okay, so I met Gail it's been 3 years now, about 2020. Serum Tears has been something I've been using in my practice for 10 years, ever since I started in my own private practice. But it's always been very cumbersome and challenging to find out how to get this therapy to my patients. And so I was very excited when I met Gail, and his company, Kits, really has this exciting solution that I think really opens the door for serum tears to become much more common in our clinical practice. So I'm calling this from sideshow to prime time, because serum tears for many years have been considered a kind of a tertiary therapy, or end of the road therapy for dry eye. And I really feel like with the modern tools that we have with aseptic technology now, it can now move into prime time is really a routine dry eye therapy in many ways. That's as or more effective than what we already have. So I do have a financial disclosure with aseptic kits. I show the slide just to bedazzle everybody here because it bedazzles me. I don't know. This is immunology at its worst, just very complex set of feedback loops that kind of, in all the multifactorial aspects of dry eye disease. This is taken from the DEWS study, which I'll talk more about. I don't expect anybody to understand this in great detail, but the bottom line is there's a lot of complex interaction of things happening on the ocular surface that contribute to the symptoms that patients have. And that helps direct what we do to treat them. The bottom line with all this is when you have dry eye syndrome, or what I'm going to call inflamed tear syndrome or ocular surface disease, essentially you have a loss of homeostasis. So you want homeostasis, this nice Zen state on the surface of the eye. And when you lose homeostasis, things go awry, and people start to have symptoms and burning, itching. And so maybe the best definition of dry eye disease is a multifactorial loss of ocular surface homeostasis resulting in inflammation. So inflammation is really the process that drives a lot of the symptoms that our patients have with this condition. As I mentioned, I like the term inflamed tear syndrome. So many patients come in and they'll say, oh, well, my eyes aren't dry, doctor. I tear all the time, or I just can't see very well. I'm blinking all the time. I can't see. And so it's not just dryness that they'll feel. It's the inflammation that they're having symptoms from. And then even a more general term is ocular surface disease, which incorporates many aspects, including the eyelids and the eyelid relationship to the eye, the tear film and all of its complexity, and also the conjunctiva and its function, and the surface of the cornea. So I'm going to have a little case presentation to start here. This is a woman that came to my practice after I started using aseptic kits. She's a 67-year-old and had LASIK in both eyes. That's risk factor number 1 for loss of ocular surface homeostasis. She had been diagnosed with this dry eye disease. She'd had retina procedures, multiple retina procedures, especially in the left eye. She had a bad cataract in her left eye, and she had this thing called a Saltzman's nodule in the left eye. Saltzman's nodules are these little calluses that form after many years of inflammation on the surface of the eye. And these bumps can create astigmatism and other problems. So she was referred. There was a concern of just doing cataract surgery in this situation where there's other things going on. And so she was referred to me to evaluate. She had tried many of the proprietary commercial formulations, Xiidra, Restasis. She hadn't felt any improvement in her vision or her symptoms. She'd been tried with steroids as well. Her acuity was really bad. I mean, she was 21/30, almost legally blind because of this cataract and other issues. She had a lot of meibomian gland dysfunction. Her oil glands were not working well. She had this Saltzman's nodule at 10 o'clock in the cornea, which I'll show you. And then she had these dry spots on her cornea. So she has multiple surface problems. She fits very closely into this DEWS criteria of a multifactorial loss of ocular surface homeostasis resulting in inflammation. And she's got Saltzman's nodules. Her surface was also neurotrophic. She didn't have good corneal sensation, which is another contributory problem in many cases. So on a topography scan on her initial presentation, I don't expect you to know these in detail, but if you look at the cornea on the right side, there's blue in the periphery, and there's some steepness in the center. That might be partially due to the type of LASIK ablation she had. But the bottom line is the scanner here was showing that she had 0.6 diopter of astigmatism. That's pretty low. Most cataract surgeons, if it's less than 1, we say, oh, that's low astigmatism. We could go ahead and do your cataract surgery. But you can see there's these sneaky little blue thing right here on the other map. That's the Saltzman's nodule that's pushing in. So I would say, looking at this, I'd say, oh, the Saltzman's nodule is not that impressive. Maybe we just do cataract surgery and not worry about that. But I said, so many things going on. You haven't tried some new things. Let's try serum tears. Let's put a little plug to plug the tear drain to give a little bit more lubrication to the eye. We also started a medicine called doxycycline. So these are things that she hadn't tried in concert yet, and serum tears being a major thing she hadn't tried. Then I said, let's just give it one more month before we try to do any surgery. And she came back, and comparing, you can see now she's got 2 diopters of astigmatism. Okay, so treating the surface of her eye, which now looked better, actually unmasked astigmatism that was being induced by this Saltzman's nodule here. So after treating for a month of serum tears, it changed my whole treatment plan for her. Said, okay, look, we've got to take this nodule off. That's going to make your outcome of cataract surgery much better. And so we did that. Her astigmatism went way down, and she had a better result from cataract surgery. So it just highlights an example of where treating the ocular surface is so important when you're, especially in any case, but in a surgical case especially, because you can unmask things that are there that you didn't know about. So, so what is the role of human tear film? Well, it's a lubricant. It has both a phospholipid layer and then an aqueous mucin layer, which is kind of all work in concert to produce good vision and comfort. There's nutritive and metabolism functions. There's glucose in tear film, oxygen, electrolytes that help nourish the cornea and the surface of the eye. It's really important to good visual performance. So if you don't have a good tear film, you can't see well. And that's a common symptom, sometimes the first symptom of dry eye syndrome or ocular surface disease. Wound healing. There's growth factors in tear film that are really important to help wounds heal on the cornea. And then it's also has or immune properties or protective properties, both innate immunity through antibodies and other mediators, and then also these anti-inflammatory mediators. So there's a very complex amount of molecules and things in the tear film that help the eye heal that aren't in your regular artificial tears, which people use all the time. Those are just basically single ingredient or very few ingredient lubricants, and they are missing all of these biologic factors. What's the closest analog to human tears? Well, it's human serum. So what better way to restore homeostasis on the surface than using an analog of human tears? This is a study that was done to show kind of the similarity between tears and serum. And going down the list here on many of these growth factors and other cytokines and things, it shows that there's really quite a bit of similarity between the two. So again, another complex DEWS flow chart here. Basically, DEWS is comprehensive in terms of trying to help us clinicians work through how to best diagnose and manage dry eye disease or loss of homeostasis on the surface. But breaking down some of these management tips from the DEWS study, they basically separate ocular surface disease into 3 categories. Stage 1 is the majority of patients. This is what I call dry eye basic, and I have an algorithm for treating these, and I do this many times a day, because in Utah where I am, I'd say a majority of my patients have some degree of surface dysfunction and loss of homeostasis. So you modify the environment. If I can, I write them a prescription to move to Hawaii, which is going to fix their problem, but that's not feasible for most people. We eliminate any systemic or topical things that they're using. Sometimes they're on anticholinergic medications and other things that can exacerbate dry eyes. I supplement with oral omega-3 compounds and use lipid-based artificial tears and hot compresses. So these are all simple over-the-counter things that people can do. A lot of times they'll mention it. They're not that bothered by it. It's helpful to have a few ideas of things they can do when it gets a little bit more noticeable. Now, stage 2 is the majority of my dry eye disease specific clinic visits, meaning that when people are referred or they're actually calling in saying my eyes are dry, this is the majority of them are in stage 2. And so these patients often switch to preservative-free artificial tears, which are a little bit more gentle. And this, again, these are the DEWS recommendations. Punctal occlusion, putting plugs in the tear drains to help keep more tears on the eyes. And then in DEWS 2, the traditional DEWS 2, they say, well, now you can start thinking about pharmacologic therapy using T-cell inhibitors and corticosteroids. So this is things like Restasis, Xiidra, and steroids. And then also treating Demodex or meibomian gland dysfunction is important. Traditional stage 3 is where serum tears appear. So as I mentioned before, serum tears are kind of these in toward the end of the row of what to do for dry eye disease. And, we might use therapeutic contact lenses as well. There's neurostimulators that stimulate tearing. Some products are available for that. And then stage 4 is the most severe stage where many long-term topical steroids. We might need to use amniotic membrane grafts, punctal cauterization, or tarsorrhaphy, and these will always encompass the prior 3 stages as well. So patients in stage 4 are often on many, many agents. So part of my evolution with serum tears is rethinking stage 2. I really feel strongly that now for pharmacotherapy does not have to just include, or maybe I would even say starting with serum tears before pharmacotherapy, something natural that has the closest analog to human tear film, and include serum tears in the DEWS stage 2. So that's kind of where I think there's a real key change in the way we should think about serum tears. And don't forget environment. Humidity is low all the time in the Southwest, low indoor. So I often have patients use humidifiers. Allergens also worsen symptoms, so treating allergy is important. And smoking is pro-inflammatory, so that can also exacerbate symptoms. So why don't clinicians use serum tears? Why is this? Why am I saying this is something we have to change the way we think? Well, they may be unacquainted with or unconvinced by their scientific basis. That's legitimate. For many years, there weren't great studies on it. I feel like there's now a pretty good consensus of studies and clinical practice that serum tears are effective. I don't think there's many clinicians in the cornea world that would argue that serum tears are not a very effective way to treat the ocular surface. There may be some that are unfamiliar with clinical applications. And then here's really the crux of it, is the complexity of procurement and the cost. So patients or they may be unwilling because they're scared of needles or something like that. But serum tears can be amazing. It's not very often you have people with dry eyes coming back to your clinic after treating them and having them be really enthusiastic about what you're doing. But these are some real comments from patients that, they're so comfortable and soothing. They're much more comfortable than a lot of these pharmacologic treatments. A high percentage of patients on Restasis, for example, discontinue the medicine because it burns. And so they just don't like putting it in. And Xiidra can cause changes in taste and things and other symptoms. So there's really no side effects that I've come across for serum tears. I mean, it doesn't mean that every single person loves them or feel like they work 100% of the time, but they're very comfortable. And I think that's pretty universal. The other old thinking with serum tears is that they're kind of obscure, they're unusual, they're reserved for severe cases. It's kind of your ace in the hole after everything has been tried. And it's sometimes difficult to convince patients, and procurement is challenging and expensive. So why go to the effort of explaining something new, collecting payment, orchestrating blood collection and processing, when it's easier to write a prescription for a commercial medication? So why is procurement felt to be complex? Well, you've got to do phlebotomy, and most doctors don't want to do that in their clinic. You have to have a centrifuge and do that. That takes a while. There's a sterile processing, which is a huge hurdle. Probably the biggest hurdle that's traditionally been there is you don't want to just be doing this out in the open in your clinic. Then storage and transport to get them to the patient with the cold chain problems that may be there. And then cost has been traditionally very high. So as I mentioned, there's significant data supporting efficacy of serum tears, and I think it's useful much sooner in a wider variety of patients. I found this very intuitive to patients. You talk about it, they like the idea of using something natural that's from their own body. And there's a lot of other therapies that use serum or PRP or other things that patients are becoming more acquainted with, and they can understand that a lot better. And they say, well, great, there's a way that we can use this for my eyes. That sounds great. And cost is greatly reduced with aseptic kits in ArcPoint, and much more simple. ArcPoint really makes it easy. So I would argue, more effective than pharmacotherapy, certainly fewer side effects, That's obviously debatable. There's no head-to-head trial between serum tears and Restasis or Xiidra, for example. But prescribing Restasis and Xiidra is not fun. If you're a clinician, you hate prescribing this because it's expensive. So patients often have a shock at the pharmacy. They can't believe how much it costs. They don't, so a lot of them don't use it right out of the gate. It takes a long time to work sometimes, 6 weeks or more with Restasis. And it's painful for a lot of patients. It's uncomfortable. So really, with all the functions of human serum, it sort of has the anti-inflammatory properties of Restasis and Xiidra, and has some neurotrophic properties of Oxervate, which is a newer agent that I haven't mentioned for nerve disease in the cornea. And it's all those things in one. It's more culturally intuitive now. It's kind of a free range organic solution, locally sourced, as local as it gets, right from someone's own body. Okay. And then there's no preservatives at all. So it's a natural solution versus an artificial solution, and a very wide application. It can be used in simple dry eye and beyond. It can be used for neurotrophic keratopathy, persistent epithelial defects, exposure keratopathy, and as I presented a case of pre or post-surgical situations. So procurement has greatly simplified it. So, in terms of being able to do this locally, traditionally people would have to rely on compounding pharmacies. These come and go. They're notoriously going out of business because of regulations. And then eye banks, some of them do it, but they're few and far between. So now we have a great local solution with aseptic kits and ArcPoint. ArcPoint is distributed widely throughout the United States, hopefully going to be in all 50 states soon. But it's very convenient for most people to send their patient to an ArcPoint lab to get this done, and they can do it same day. There are national chains. Vital Tears is probably the primary competitor to aseptic kits, and they have a 48-hour or more turnaround, and there's added shipping costs. It's very expensive compared to the ArcPoint solution. So this is a local solution. It's convenient, cost-effective. There's a fast turnaround, and the patented kit-based sterile preparation really eliminates the risks of contamination. In fact, it's more effective at eliminating them than doing this under a sterile flow hood, in our opinion. The filters are even smaller pore size than the HEPA filters in flow hoods. It's a closed system, technique independent design that provides maximum sterility assurance. So here's a kit in action with some diluted serum tears being pushed through the filtration system into the Pala. This looks like a Pala 8 kit. No, Pala 12. That's a Pala 12 kit there. It's sort of like a clean room in a bag. You can do this really anytime, anywhere. It meets or exceeds the 797 guidelines for ophthalmic sterile preparations as recommended by USP. And no laminar flow hood is needed. So no flow hood. This is the beauty of this way of doing things. And, cost of serum tears can be as high as $600 to $700 using Vital Tears. Eye banks are often in that range as well for a 6-month supply. This, depending on the franchise of ArcPoint, can be $250 to $500. And really, as a company, our goal is to make this affordable for people, make this, available to as many people as possible. As a way of comparison, this is, I think, a much more cost-effective solution than, $500 a year almost approaches the cost of using preservative-free artificial tears over the counter if people are using them frequently, and certainly much less expensive than a year's worth of cyclosporin or Lifitegrast, Xiidra, or some of these newer agents. And Oxervate is so expensive; it's almost $90,000 for a treatment course, which is typically about 8 weeks. I mean, I think it's criminal. I mean, the Medicare should require serum tears, and they should pay for serum tears to be tried before they go paying $90,000 for Oxervate. Some people, they have defects in their cornea that don't heal because they have poor nerve input. They're the ones that get on Oxervate. But serum tears can often heal these defects as well. So I think I would hope that would be something that Medicare would see a value in. So in conclusion, dry eye disease is a complex multifactorial condition resulting in loss of ocular surface hemostasis. Serum tears are an effective treatment that can and should be considered for patients much earlier than traditionally taught. Aseptic kits technology has greatly simplified the procurement and of serum tears at a reduced cost, enabling us to rethink the role of serum tears. And ArcPoint Labs is an excellent partner and an excellent local source where the technology can be applied for patients to benefit from serum tears in a convenient and cost-effective manner. We also have other things in the works. We have a kit that's designed to be used to produce compounded antibiotics and other ophthalmic preparations. So we're really trying to revolutionize the way sterile preparations are thought about and made in ophthalmology to make it much more convenient and available. Thank you very much.
Great. Thank you so much, Dr. Ward. We do have a couple of questions that have come through. The first one is, Dr. Ward, could you please distinguish specifically between PRP and serum tears?
Yeah, so it seems like this is a common question we get every time. I think the main issue is that PRP is serum plus plasma or platelet-rich plasma. So you have platelets in PRP, whereas you don't have platelets in serum. So what is the difference between them in terms of clinical benefit? I don't know side-to-side comparisons, serum tears over PRP. I look at it as just another tool in the toolbox. So right now we don't have a means of preparing PRP with kits, but there may be a patient you try serum tears. First off, I would increase the concentration of serum tears. So we usually start at a 20% concentration. I might go to 40%, or maybe even it's really severe, do full 100% serum has been tried as well. PRP is let's say that doesn't work. Patients still have symptoms. That's PRP, something you could try, but that's harder to get and harder to procure. But that's the difference between them.
Excellent. All right, we got big thank you for the comparison information there. One other one, I'm not sure if we can answer this one, but it says, do you know the effectiveness of Tyvaia?
Tyvaia?
Yep. Tyvaia.
Yeah, Trevia. Yeah, that's pretty new. I think in the last couple of years, it's a direct agonist of the tearing function in the lacrimal gland. So it's basically a nasal spray. Put a mist in the nose, and it stimulates the lacrimal gland to start cranking out tears. I think it's a great option. I think it's cool. I'm glad people are thinking outside the box, trying to find ways to help. So that would be a way of actually stimulating natural tear production. It's very expensive. I've had a few patients that have tried it. Some of them it works really well. So it's just one other thing available to treat patients with.
Excellent.
But it's expensive.
Excellent. Well, I don't have any other questions coming through. Does anyone else have anything else? Otherwise, as always, Dr. Ward, we appreciate your time. Thank you so much for doing this for us over and over again. We really appreciate it. Oh, we did get one more. Hold on. How do you recommend how the physician selects the percentage? Well, you kind of mentioned you start off at 20 and just kind of titrate up, but can you elaborate on that a little?
Yeah, I think you want the patient to get the most bang for their buck. So I try to get, I don't think I've ever gone below 20%. I usually basically take whatever volume of serum comes out of the centrifuge. I tell my technicians just use all of it to make their tears. So that usually ends up being 20 or 25%. And that allows them to not waste any of the blood product and also not waste any of the bottles that are in the kit. Because if you go above that percentage, you should probably either use a Paula 8 kit where you fill fewer bottles with a higher concentration, or you're going to end up wasting bottles that are in the kit because your volume of tears are lower. So I basically just say, let's just start by filling all the bottles. I use the Paula 12 kit mostly, and fill them all so the patient has as long a treatment course as possible. And if they're not responding for whatever reason, to that concentration, then I might say, well, let's try a higher concentration just keep in mind, it's still the same cost, but you may get, half the bottles or something like that. So it's just going to be more expensive for them.
Okay. We had someone asking about the PowerPoint. Yep, we will share the slide deck and the recording with anybody who's registered owners. You'll have access to it on SharePoint, and then for all of our physicians and guests, you'll get a follow-up email with those materials. One more question: what is the insurance coverage for the agents other than Serum Tears?
Yeah, it's a highly variable. That's one of the big frustrations for clinicians is, you don't have time to navigate who's covering what, and it changes all the time. The reps come in all the time and they give all these booklets, they call them copay cards. And so those are some of the most maddening things I've used, because I give them the patients thinking they're going to give you this such and such amount free, or you'll get this much off your copay, whatever. I still just get kind of angry phone calls back like, oh, it's going to be $400 for 1 month, or, it's going to be this. And so I really, it does get covered sometimes 100%. And so, some patients, I have a lot of patients on these agents. It's not like I never prescribe them, but I prescribe them far less now that I have the ability to do Serum Tears, just because I find it easier for patients, more effective, and,
Perfect. All right. Another question. I think I can handle part of this, but Gail, Dr. Ward, you're more than welcome to also chime in. Is a prescription required for Serum Tears? I have heard that it is not. How about a doctor's order or an order from an optometrist? So the short answer is no. Technically, you don't need a prescription for Serum Tears. All that being said, it's much better if it comes from the directive of a physician. It could be any type of physician or healthcare provider. We have those convenient prescription pads that we make for you guys to provide to your physicians. So I'll stop there and turn it over to Dr. Ward or Gail if you guys want to elaborate on that.
Well, yeah, I think it's going to be most effective if you're a franchisee and just to establish a relationship with the doctor. Yeah, technically, if a patient came in off the street and wanted Serum Tears, you can probably just make them for them. I mean, there's no regulatory aspect that we're aware of to Serum Tears, especially when you're using aseptic kits to have a sterile preparation. But I think it's in your best interest to use the prescription, because it maintains that relationship with the doctor and allows you to continue to receive their referrals.
We would also just like with any of our other services and tests, if there's something else going on, we would want the healthcare provider to be involved to be able to kind of navigate that.
Mm-hmm.
And then I would say not to just consider optometrist and ophthalmologist. I mean, serum dry eye disease affects a lot of people, a lot of different areas. So really, I don't know, Gail, do you want to elaborate a little bit on some of we've talked about LASIK centers, or what are some other areas that might be interested in offering Serum Tears?
Well, there are a number of professions or areas of medicine where Serum Tears patients are going to be more prevalent. And this is probably a better question for Dr. Ward. I was going to say doctors treating diabetic patients, certainly chemotherapy, oncology centers have a lot of dry